Okay, we'll make a start. So good evening, ladies and gentlemen, and welcome to the formal meeting of the Adults Health and Social Care Scrutiny Board on this quite a miserable day compared to what we've been used to. It's going to be it's a bit of test and see. We've had two informal meetings that worked extremely well. So I'd like to welcome members of the public, for anyone who is listening in tonight. Copies of the reports are online. And we'll go through the official agenda. It's quite a challenging agenda this evening, and quite a few reports to go with some of the items. So we'll continue and bear with. Substitutes nominated for this evening. I don't think we have any.
None received, Chair.
Okay, marvellous. Thank you, members. For members to report any items that they have any interest in, as always. Item 3, admission of the public. This meeting is open to the public except for under section 100A, section 4 of the Local Government Act 1972. It is recommended that the public be excluded for the following item of business on the grounds that it involves the likely disclosure of exempt information as defined in the stated paragraph at part 1 of Schedule 12A of the Act, namely item number 9, which is a health and social care integration, paragraph 3, financial or business affairs. I had to read that out so members of the public were aware why we're having an exempt item. We don't normally have an exempt item in the adults. This is a one-off. Okay, so item number 4 is the minutes of the Adults Health and Social Care Scrutiny Board held on the 27th of February 2020, which seems a decade ago, but can I have a proposal for those?
Okay. Sorry.
Colin, would you like to say something?
Chair, yes, please, Chair. I agree. I had a great sense of nostalgia reading those minutes, but there's on page F48 in the final paragraph, there's an error. It should read, a number of viral conditions could shed the virus before symptoms occurred. Was this the case for COVID-19? Otherwise, it doesn't actually make sense.
Yep, okay, take those on board.
And there was what, otherwise I'm fine with it, but there's one matter arising that I'd just like to ask.
Okay, if you'd like to go ahead with that now, if that's okay, please.
On page F50, paragraph 3, it says Councillor Metcalfe mentioned a review of dental services in 2007 with 25 recommendations. And there's a suggestion that that review should be shared with us, but I don't recall seeing that. And I just wondered whether it could be retrieved from the archives and put before us. But otherwise, I'll propose the minutes.
Fabulous. Do we have a seconder for those minutes? Yeah, marvellous. Councillor Mike Barnes, sorry. So all those in favour, if you can just show with your hands. Yeah, okay, moved, and we'll get a copy of that. I think events have overtaken Colin Hutchinson, so I think we'll get a copy of that, and we can bring that up as and when we go forward. Right, okay, so item number 5, the COVID-19 briefings. Do we need to bring people in at this stage, Kirsty?
Yes, it might take me a while. So
just bear with everyone. Equally, whilst Kirsty's doing that, there are a number of reports that have been circulated prior to the meeting. What we'll do is raise any questions as and when at the appropriate time. What we'll do at the end is just to make sure we've covered everything, just go through each report just to make sure there's nothing further to add. As I said, the reports don't always match with the actual agenda items, so we'll try to fit in as much as possible. Okay, I can see various people joining us, so welcome Ben Lehman, Jill Holbert, Sean Cook, Karen Walker, Anna Basford, David Birkenhead, Tim Breeden, Neil Smurthwaite, And Debbie Graham.
Believe that is all, but let me just do a final check, councillor. Good to go.
And sorry, Kirsty, if you could bring in Ian Baines, I think, as well for this item.
Sorry, Ian, I thought I pressed you first, to be honest.
Okay, welcome Ian, and welcome all the members that have joined us, and thank you very much indeed for taking your time this evening to report on the various issues relating to COVID-19. So if we make a start, if we can start with the public health actually. So Karen, would you like to just give us a bit of an update from the public health perspective?
Yeah, we're going to do it between us, Ben and I, because we're doing different bits. So I can do my bit, which is around the care homes prevention strategy, and then Ben's going to do a bit around test and trace. Is that okay? Yeah,
of course it is. Yeah, that's perfect. Yeah, if you continue, that's we have had the reports. So I think it's just above and beyond whatever you'd like to report with the actual reports, if that's okay.
Yeah, that's absolutely fine. Well, as you can see from the paper, there were 6 objectives around discharge, regular testing of homes, surveillance, training and support, especially around IPC, reviewing auditing comms, and that was the 6 areas that we identified in terms of keeping care homes that didn't have any COVID remaining COVID free, and you know, I'll give you the up-to-date figures on that one. So I won't sort of dwell on that. So we've been working on that first stage of that plan, which was very much around training trainers to do training in the care homes with staff. And over the past month, of the 48 care homes in Calderdale, all those 48 care homes that were COVID-free were offered training. Of that, 21 face-to-face training, 14 received virtual training, and 13 declined the training. But a lot of those that declined was because they weren't able to fit in with the initial timescale. So we're kind of mopping that up now. So really, we've moved on a little bit since that paper was submitted, and we're going to identify. We've got a number of recommendations. That's kind of phase 2. So it's around the basically objective 4, 5, and 6 really, around extending the programme of training, and more than that, really embedding that effective practices across all the staff groups, because that's really important in terms of sustainability to go forward. If we make sure that that's embedded. We also want to provide ongoing support to care homes, both for the staff there, but also to the care home managers to enhance their leadership. Something that's come out of the work that we've done so far is the importance of the leadership of managers. If the managers are engaged and working with the team, that has a impact. So some support to care home managers. Also support to staff, and we're doing a number of things around staff, not just around IPC, but we're about to, in the next couple of weeks, put out a questionnaire to all the care home staff around their health and well-being, both the physical and mental well-being, asking about what it's like at work, but also, you know, the pressures that they might have at home as well, whether they're informal carers. So that'll be going out in a couple of weeks as well, so that we can then tailor some support into the care homes for those staff. And I suppose what I would say now, really, we've got an ideal opportunity now to have an approach which is kind of fit for the future and have the ability to build on the current good work that we've done. And it has been a partnership. It's been a really good partnership across the system, but also so that we're ready for things like winter, things like other pandemics, and provide a good IPC service. At the moment, we still don't know whether there'll be a second wave, but certainly if the hospitals are expected to operate at 70% over the winter, that capacity can be achieved if we've got a really good care home sector to support that, now more than ever, if we look at last year. So we need to look at how we actually have that sustainable future. So we're now looking at how we might create that investment across the system, to escalate that across the wider system, so it is a system response. So I don't want to say any more on the prevention plan, but it's basically keeping care homes free of COVID, and keeping it that way. So I'll leave it there, Councillor.
Yeah, thank you, Karen. Thank you for that. Ben, would you like you're going to report any questions in relation to that? Yes, Councillor Lee, please. You just need to unmute yourself. Sorry, that's something else you need to do whenever you speak, and then mute yourself back again. Just bear with members. He's just muted himself again. Unmute.
Hi. Is that okay now?
That's good. That's better. Thank you.
It was just a query in that last report. There was talk of a potential second wave, and everybody will know that there's differing opinions about whether this coronavirus is likely to have a second wave or not. But yesterday, earlier this week, it would appear that Beijing seemed to have a reaction that they weren't expecting. So just a question to the previous speaker, is a second wave still considered something that we've got to be particularly careful about in view of current developments?
Thanks, Councillor Lee.
I think we can't rule it out at the moment. We don't have enough data to know. I think the issue in China was a one particular location, but at this moment in time, I don't think we can say whether there'll be a second wave or not. It's one of the scenarios that we have to consider.
Councillor Hutchinson.
Thank you very much. Given that whether it's a second wave or whether it's just a spike in cases within the first wave, because my understanding is second waves are often quite a long time after the first one. How well do you think we're preparing in terms of securing local supplies of personal protective equipment, stockpiling the necessary supplies for future, in that eventuality? I know it's been hard to actually get sufficient supplies to maintain the day-to-day supplies, let alone stockpiling, but I was wondering whether long-term contracts, this is going to be with us for quite a while, whether long-term contracts with local suppliers of primary personal protective equipment are being set up yet.
If I can actually pass that one to Ian Baines to answer, because he knows all the figures around the supplies that we've been able to get around PPE and what we'll be doing in the future. So I'm going to bat that one over to Ian, if that's all right, Councillor.
Yeah, of course it is. Yes, absolutely.
So in terms of PPE, we have developed really early on in COVID a PPE cell that looked particularly at sourcing PPE for social care and primary care. And to date, we've distributed 917 individual pieces of PPE. And on top of that, things like hand sanitizers, etc. What we have done is created confidence in our supply chain, and Councillor Hutchinson's right. At the very early part of the pandemic, some of the international lines of our delivery chain were disrupted. Some of those have been re-established, but we have also looked at local resources. So part of our plan is to have a series of local providers where we know we've got some continuity of delivery of supplies, but also as part of the wider West Yorkshire and Harrogate developments, we're looking at how we might procure at a West Yorkshire level, again using West Yorkshire resources and manufacturers. So we are securing local delivery.
Thank you.
Good, excellent. Any other members indicating to speak on this item? I can't see anybody, so
Councillor Megan Swift's
sorry, Councillor Swift. Unmute yourself, please.
Right. I don't know which way round this is, but as far as I can tell, and it's on the news on there now, we have an outbreak of this in Kirklees, of which I believe some of the staff who are involved are actually Calderdale. So I wondered, you know, what was happening, and did we all know that?
Who would like to pick up on that?
Nobody they can help it.
Karen, I think you might want to pick up on that.
I can do. We have been notified of an outbreak, and certainly the Kirklees IPC team and Public Health England are dealing with that at the moment, and they will inform us when there's any aspects that affects Calderdale, but they're leading on that investigation at the moment. That's all I can really say at the moment.
Okay, no worries. Okay, thank you for that. Anyone else? I can't see anybody else indicating to speak. We've got a lot to get through, so let's just before I do, we have had a nice email from Welcome Independent Living Limited, an acknowledgement and thanks to Calderdale. So we can circulate that after the meeting. Kirsty, at this stage, Councillor Greenwood has sent her apologies because she's unable to get onto the Zoom meeting. So if you can just note her apologies, she's going to catch us on YouTube and email any questions she may have. So can we move on to Ben with the test and trace system, please? As I say, we've had your report, so it's just about anything extra you want to add to that, please.
Thank you, Chair. I'm sure you've all read the report. I think contextually, it's really important to see this as part of a broader programme around trying to reduce the level of infection in the community as a whole. This is one aspect of it, but many of the things that we're additionally doing in Calderdale that are quite visible at times in terms of some of the social distancing within town and within workplaces, but also some of the work that Karen's described and some of the work my colleagues in the CCG will describe later about, and other bits of the health system will describe about what we're doing to prevent infection to start with. Where we do get infections, the national programme, the National Test and Trace programme, is there to ensure that where possible we manage outbreaks as quickly as we can to reduce the likelihood of community spread through a large-scale outbreak. So this, in effect, is part of the mitigation plan for us in terms of preventing a second wave. But it's also broader than that. If we can get infection rates really low in the community, it allows us to reopen aspects of the community that still at this point are in lockdown. So it's really important in that context too. You've got the paper, you've got the detail. I really wanted to draw your attention to the themes which are on page 4, which really are the background to what we need to do locally. This is a national programme. We've got some local things we need to achieve. So we need to be able to respond to outbreaks in particular settings and within communities quickly and effectively. We need to ensure that we can mobilise testing if we need to at very short notice, and do that in the places it's needed where outbreaks may be occurring. We need to ensure that we've got the ability to call on mutual aid if we have a significant incident within Calderdale, and we also need to ensure that we're making the most of the data that's available to us and that should be coming through the Joint Biosecurity Centre as that becomes more established. we've got a key role around supporting vulnerable people, and this is in terms of supporting them to self-isolate, but also supporting them to get tested as well. We've got a role around establishing the governance processes around how we operate all that locally. All of that is really important, and it's underpinned by having good comms and engagement in place, by having an effective use of data across the system. It's about having good support in place in the same way as we've been supporting those who've been shielding over the last 3 months. It's about having very nimble and responsive testing, and being able to escalate a response team if we do get any outbreaks, manage it accordingly. I won't go any further than that. I think I'll open it up to questions if that's okay, Chair.
Yeah, no, that's brilliant. Thank you, Ben, for that. Councillor Megan Swift, please.
You just pop yourself on mute, Councillor Swift, sorry.
Can you hear me now?
We can indeed, yes.
Oh, sorry, I must have taken it the wrong way. Having read the paper then, it talks once again about not having possibly enough people going through the testing system. It talks about, because of the small numbers, we're only doing one every 2 days in Halifax, and they're doing the same in Kirklees. And this doesn't sound a great deal to me when, you know, we hear about staff that would actually like to be tested, etc. Why aren't we filling these slots?
So I think we have seen an uptake, an increase in the uptake in testing from staff. I think there's more to it than just the site that we have locally. We have the national site, so people in the community can travel to Bradford or to Leeds, or we can get home testing kits sent to them as well. And we also have the mobile testing units, which are in Todmorden today and tomorrow, and are regularly in the borough as well. So I think we have lots of testing going on, and it's widely available to staff. There's an ambition that all health and social care staff will have received a test over the next month or so, and that's already happened for a significant proportion of the system already, and that's part of the process too. So I think certainly the impression I get from speaking to colleagues around the borough is that where staff want a test, they're getting a test. Where we can get broader testing of people without symptoms who are working in high risk roles, that's happening too, and that should be rolled out to everybody across the system within the next month. So everybody should have had a test who's working in frontline. I think what I would say is it's not mandatory. We can't mandate that everybody takes a test. It's an issue of personal choice, and some people will choose not to do that. But I think what we have seen is a really good response actually from our frontline workers in health and care to getting tested, and particularly where they've got symptoms.
Okay.
Can I just come back?
Yes, of course, quickly, yeah.
Thank you. I am not picking fault with anybody on the front line or whichever line people are working on. They're doing a tremendous job. It was just the planning when I thought there should be enough people want it if they know they can ask for it. Now that seems to be the bit they're waiting to be told they can have it, and if that bit doesn't happen, it falls down. But nothing, you know, it's not a criticism of anybody doing it, because the whole system, as far as staff are here and everywhere else, you know, we seem to be very, very fortunate at the level of stuff that we're doing.
Okay, I'm going to bring in Councillor Hutchinson at this stage.
Thank you, Chair. Test and trace by itself doesn't actually achieve an awful lot. You need to have an effective system of isolation and support for people who are being called upon to isolate. Similarly, we really need to be going out and actually tracking down the virus and people who are affected by it. So the description of it as being a find, test, trace, isolate and support system sounds to me a much better description. Can you think of what barriers there are that we need to actually demolish to make such a system more effective? And I'm thinking of the barriers you've alluded to people for one reason or another not wanting to be tested, whether that's because they're suspicious of where their personal information might end up with, or the effect it might have on their life insurance policies. And for isolation, the level of financial support that's available to people who are being asked to isolate may actually be a disincentive for some groups of people who are on the edge. Are there any things that you think we could do that would actually give us a world-class system here?
Thank you, Councillor Hutchinson. I think you've answered some of your own question there. I think the bit about what could we do about that, I think I recognise exactly what you've said. There are financial disincentives to self-isolate potentially, and particularly for those who are self-employed, and that's recognised locally, but it's also been escalated through the Local Resilience Forum, which operates across the West Yorkshire footprint. There's clearly more that the system should be doing nationally to support people to isolate, and we'll keep pushing for that. I think it is really important. With regards to whether people necessarily trust the use of the data, I think there are things we can do around that in terms of the testing bit of the system. Certainly, I'm aware of a pilot that's running in Bradford to test that out, for example, where people don't have to give a phone number, an email address and a name. They get a code and they ring up to get the result using a code. So I think that's something we'd look to explore. The testing is obviously really important as part of this. You can't do any of the rest of it until you've got the testing. And as you alluded to there's an element of finding as well. I think we call it test and trace because if we called it all of the different things that are involved in the process, it doesn't quite roll off the tongue as easily. But there clearly is much more to the process than just the test and the trace bit.
Okay, thanks for that, Councillor Naeem. Councillor Naeem, did you want to ask a question? Okay, we'll go on to Councillor Lee then in that case.
Yes, thanks, Ab. No, hello, I'm here. Hello.
Okay, thank you. Ask the question, please. Yeah.
Yeah, sorry. It's really in relation to this test and trace thing. What are we sort of saying to people in terms of those who want to be tested? Are we saying to people that they should only go for tests if they've got symptoms? Or are we sort of saying they should test themselves anyway because they're in a kind of a category where they're at a high risk, or they're from a particular sort of community that could be regarded as high risk? Because the situation that I've got is those people who go when they haven't got the symptoms and they come back negative, and then when they sort of, are they allowed to go back when they do get the symptoms? So it's a bit confusing in that sense. You know what I mean? So what are we saying to people? When should they go for the test? Only when they have symptoms, or can they go at any time?
Okay, so there's a clear message to the public here, and the message is got symptoms, get tested. We're not suggesting that people without symptoms should get tested routinely, unless they're working in a frontline health and care role, and that is being managed through the health and the social care system, and we're working to support those individuals. The only other time we may consider testing for people who don't have symptoms is in an outbreak scenario, where, for example, you might have a school where 4 or 5 children from the same school have got a positive result, and we may want to then screen more widely to see whether anyone else also tests positive in that context.
Okay, thanks for that. Councillor Stephen Lee, please. You've just muted yourself again, I'm afraid.
Thank you. This is another question for Ben. Ben, I realise this is very difficult possibly to answer because this whole situation is so fast moving. But I'm interested in the trace element of what we've been talking about. And I see today that the trial system in the Isle of Wight has been dropped in favour of an alternative system. So will that have any impact on what you have to do now to train staff for an alternative methodology for the tracing element of this process?
So one part of the tracing element consisted of the app, as you allude to there. The app was tested in the Isle of Wight. I think there were some significant concerns that arose out of the use of the app, and then I think it's been recognised now that they're insurmountable and we need an alternative. What I would say is the app's only one small part of the programme. What's really important in terms of the programme is that those people who test positive are contacted by the NHS and asked to provide details on who they know that they've been in contact with. And that's the substantive bit of the programme. The app adds to that, potentially, if it's working well. And I look forward to seeing the alternatives that they put forward operational, because it will add additionality. But it's not a programme that relies entirely on just having the app. It's a nice addition, I think.
Thank you.
Thank you for that. Nobody else is indicating to speak, so I think we'll move on swiftly at this stage. So thank you, Karen and Ben, for providing us with a bit more meat on the bone. So thank you for coming on that. Right, okay, I'm going to go on to adult health and social care. So Ian Baines, can I bring you in at this stage?
Councillor Bladborough, Councillor Clark was trying to get your attention.
Okay, yeah, sorry, Councillor Clark, yeah. Would you like to come in?
I'm back, people, sorry.
Thank you, Chair. Talking back to test and trace again, there has been reports that an awful lot of the tests are coming from unknown locations. Can we do anything about that? Is there any use to that information? If we don't know where it is, how can we contact? Well, I know we can contact people from that system, but nevertheless, we need information locally where the tests are.
Yeah, so I agree. The data flows have improved a lot. We still don't get the information through that tells us exactly where positive tests are, but other places in the other bits of the system do at more of a national level. So what we will get told is if, for example, more than one person tests positive in a particular setting, or in a healthcare setting, for example, the health bit of the world will get told if there's any positive results within their setting. So I think as far as settings goes, I think we've got a fairly responsive system. I think the bit we'd like to see improve is the information flow around communities and localities, and whether we can start monitoring that more. We've been assured that that information will be coming through. I think that's critical for us, and I think it's critical for our response in terms of protecting the health of our population, really. So we look forward to receiving that when we do start getting it.
Can I just make another comment? I understand that the national insurance number is requested rather than, say, the NHS number. Would that make any difference? If maybe both were questioned?
Yeah. I have to admit, I'm not sure of the detail of what information is requested on the test in that respect. I can certainly find out outside the meeting. I haven't filled in the form myself, so I'm not quite sure exactly what they asked for. But I think the most
useful piece of information would be the postcode of the person being tested.
I agree. I think it's about having that accessible to us at a local level that becomes really important. And those conversations are ongoing nationally to ensure we get it, and we have been told.
I'm not sure that if someone went from Halifax to Leeds to have a test, whether that setting would be useful to the people of Calderdale. Not at all, really, would it?
So we know where we would know if a Calderdale resident came back positive, it wouldn't come back as a Leeds test. It would come back as a Calderdale resident, if you like.
So they do have
we
a
know
postcode
when. So they'll have the postcode they put in for the test. Yeah.
Right.
I think Nigel's just given some information around the national insurance number. Nigel Taylor GP has put some information in there to say it's voluntary in terms of giving a national insurance number. So that answers your previous question as well.
Okay, thank you.
Okay, thank you. Thank you, members. We'll now move on to Ian Baines, and you've circulated your PowerPoint slide, which was extremely useful. Do you want to add anything to that, please, Ian?
I think the bit I would like to say is that I think I want to pay tribute to everyone that works in adult social care, whether it's council employees or our partners. I've worked in Calderdale for the best part of 7 years now, and I think the way in which Calderdale has risen to the challenge that the COVID-19 has created has been amazing. And I think that sense of collaboration has helped us through some really difficult times. And as you'll see from the presentation, we talk about the impact at its peak and where we are now. And I think that's because we took really decisive action very early on, and we've worked collaboratively with our partners and with health. And I don't think we could have achieved what we have done without that. And that's not to say that there haven't been some really painful experiences for people. And we have experienced some deaths in our care homes, and every person that has died has a history and have family and friends. So that's a tragedy. But I do think that the work we have done early, I am proud of. And I think what we've been able to do is establish trust and confidence in our social care providers and the people that consume social care. So I'm proud of that. I quite would like to highlight a couple of things, if that's okay. So I think that the part of what we would normally be dealing with in social care at any one time is about 2,700 people. And those people have continued to receive a service. In addition to that, we have taken on the work of the shielding, which is highlighted in the presentation. And at the moment in Calderdale, we have nearly 9,000 people who are described as being extremely medically vulnerable that need shielding. And we've been working with those people to try and work out how best they can be supported. And that's a significant number over and above who we would normally support. I think in an earlier response, I talked a little bit about the role that we've taken on in terms of supporting the sector with PPE. And again, we've nearly now distributed just under 1 million pieces of PPE. And I think that that's been really well supported by our providers. And I know you referenced a letter of thanks that was given by one of our independent providers. I think we could supply you with more. I think people have been really grateful for the fact that we've been able to give them some confidence in PPE to be able to deliver care safely and effectively. I think I'll probably pause there because I think everybody's seen the presentation, and I'll just let answer any questions.
Indeed. So it starts off with Councillor Hutchinson, please.
Thank you, Chair. As you've said, I've certainly received quite a lot of comments very favourably from people who work in the care home and residential home sector of the support that they've received from Calderdale Council. So that's been great. But obviously this crisis has quite a long way to run. How do you see that support developing over the coming months and possibly into the longer future, if at all?
I mean, clearly, the potential risk of a second wave is in our thinking and how we might plan for that effectively. So we have developed as part of our approach something called the Care Home Resilience Plan, which is actually going to be effective across all social care settings. And Karen alluded to it in her presentation earlier, which is we've now got a long-term effective plan around how we will prevent outbreaks of any kind, not just COVID, how we'll support care homes to be more effective around infection control, about supporting their leadership and development with their workforce, and help with recruitment and retention, but also in terms of PPE supply. So we have got a long-term commitment to work out how we can work with the sector to add resilience. Now, the challenge of that is that the current funding that's been made available is short-term funding. It has helped us incredibly to do that. And one of the challenges is about what the long-term funding profile will need to look like for social care. And I know there's a lot of national debate, and that debate has gone on for a number of years about how we best fund social care. But I think if one thing comes out of this pandemic, people have realised the value of social care, but it's relatively undervalued in terms of investment. So I do hope that national policy will take this on.
Okay, thanks for that. Can I bring in Councillor Barnes, please?
Thank you, Chair. I think slightly echo what Councillor Hutchinson said, but also my dealings when I've had to speak to Ian's team on behalf of some of the residents. I think the feedback has been positive, and the manner in which they've and the speed in which they've handled things has been testimony to the team. I think. Looking forward, Ian, I'm looking at what are the key lessons we are going to learn out of this, and I think yes, this pandemic is the marathon, not the sprint that we've heard all before, but we've had one now. There is a likelihood of another one related. What lessons are we learning from this that we're going to be taking forward?
I think one of the things that we have learned very quickly is, and I think the legacy of what we've done so far will help us with this, is that, for example, in our care homes, a lot of the care homes weren't digitally enabled. So through the work we've been doing, we've tried to create access to technology for a number of our providers, which I think actually will stand us in good stead, not just for another COVID outbreak, but for how we might support care homes going forward with such things around telemedicine, etc. So I think there are some things we've put in place for this particular period of the pandemic that will have a long-lasting legacy. I do think, and I've said this to Scrutiny before, and part of my role as an officer is to be politically neutral, but I do think part of my role is to lobby for the sector. And I do think we do need a long-term funding solution for the care sector. And I think that we have to learn the lesson that what we've got in social care is highly skilled people doing very demanding roles. It just happens to be that the monetary value of those posts is low. It's not a low skill and low paid profession. It's a highly skilled profession that needs to be recognised and supported to do so. So I think part of my role is to lobby for the long-term investment in the sector. I think what we will also need to think about is how we bring providers together in localities to support each other. And I think one of the real testaments to our sector has been the collaboration between providers and sharing good practice and supporting staff. I think one of the other lessons we need to learn is the role of agencies in social care and the occasional over-reliance on agencies. I think most quality care is dependent on a resilient workforce. So one of the things I've been tasked to do on behalf of our health and social care system is to lead a task force to look at the long-term future of social care and in particular care homes. And one of the work streams that will look at is about creating a workforce that's committed and retained in the social care sector.
Thanks for that, Ian. Can I bring in Councillor Hutchinson again, please?
Thank you, Chair. I'd certainly echo those comments that you've made and wish you the best of luck in lobbying for them. We've heard that the government's shielding scheme and the associated support that comes with it is due to end at the end of July. How will services be approaching the challenge of winding that down?
So the shielding programme was originally established to run up until the end of June. And there are some speculations that this week there'll be an announcement on shielding. We did have an announcement a few weeks ago about a slight easing of shielding, which was allowed people who had been shielding to go out for a form of exercise once a day. I don't know what that shielding programme. This is the top result. I'm not sure what. Apologies for that. I'm not sure what will happen once we get the new guidance on shielding, whether it will be totally removed or not. But I think we've got a cohort of people who've been asked to shield because of they're extremely medically vulnerable. And I think they'll be reluctant to suddenly move out of complete easement. So I think one of the things that we have agreed as a system we will look at is how we can support people on an ongoing basis. And I think occasionally we do fall into the trap of describing the shielding group as one community. Behind that shielding list are a series of people who may have been living with their long-term condition for considerable time and managing that really well. People with a new diagnosis and are coming to terms with that diagnosis, and some people that might be at the end of their life. But I think it's incumbent on us as a system, irrespective of what the national approach to shielding might be in the future, is that we offer some support to them, whether that be through services like my own or through the third sector. But I don't think we can simply turn off the tap of shielding that easily. I do think it's incumbent upon us to think about that very carefully and see some support going forward beyond any date of June or July.
Okay, thanks Ian for the answer with that. Anybody else indicating to speak or ask a question to Ian at this stage? No, right, let's move on in that case. So welcome to the Calderdale and Huddersfield NHS Foundation Trust. So thank you for attending this evening. Anna, do you want to add anything to the report that's already been circulated?
Thank you. Yes, I'll introduce the report, and myself and David Birkenhead will be able to respond to questions arising from that.
Thank you.
So the report that's been submitted provides an overview of the actions that have had to be taken during the pandemic to respond. And that broadly falls into three areas. It's been about how do we organise our services to provide the capacity and the right skills to respond to the volume of patients presenting to hospital with COVID. And importantly, within that, about us being able to step up our critical care capacity and to provide zoned areas within the hospital for COVID positive patients and maintain social distancing across our services. Importantly, that has necessitated that we have had to suspend all non-urgent or non-emergency work within the hospital trust. The second key area of response has been around our partnership working, which has been referred to already, and some really positive examples, as Ian has said, around working closely with social care, around support to care homes, around discharge pathways, and also with the hospice around end-of-life care and pathways. The third area has really been around the protecting our staff and all of the issues associated around personal protective equipment, around social distancing, around enabling people to work in new ways from working from home, and most importantly, supporting their well-being psychologically and physically during this period and currently and ongoing into the future. Moving forward, in the position we're in now, our approach is one of being very cautious about how we now move forward. Whilst we have experienced a reduction in the presentation of people to hospital with COVID conditions, we have a significant backlog of people with non-COVID conditions requiring treatment. And how we provide that is going to need to be different in the future to ensure that there is segregation of COVID and non-COVID areas, that we have adequate supply of personal protective equipment, around testing, and also the very fact of using personal protective equipment means that the ability and the volume of activity we can deliver is not the same as it was previously. So we're currently undertaking some very detailed and difficult capacity and demand analysis around that, thinking towards the future, mindful that we will see inevitably increases in volume of activity going into a winter period alongside a significant backlog, and also, as has been referred to, a potential risk for second surge around COVID. We are making time, importantly, to learn from our experiences during this phase, because whilst it's been extremely challenging, there have been some really positive examples where the pace of decision making has enabled some quite transformational changes in the way we work to be implemented very rapidly. We want to keep those positive changes as we move forward. So we're really spending time talking to colleagues and with our partners across the system to understand that. So I'm going to stop there, and as I say, myself and David Birkenhead will be able to respond to any questions.
Thank you, Anna, and thank you for being so concise with the report. It's quite a complex area, and it has been quite challenging as well, I'm sure. So thanks to the staff and colleagues, of course, as it goes without saying. Right, so questions, members. Any questions? Yes, Colin Hutchinson, Councillor Hutchinson, please.
Thank you very much. As you've mentioned, there were long waiting lists and capacity problems before coronavirus struck, and things haven't got any better. And because of the way that you're being asked to reduce the bed capacity in the hospital so that patients aren't so close together and can be looked after in greater safety, that adds an additional constraint. I was just wondering what the current use of the independent hospitals in Calderdale and Kirklees actually is in terms of the amount of use that they're getting, and how they fit into the way that you see the system being in the future, and who will make the decision as to exactly how work flows through them if they are a part of the medium-term solution to capacity issues.
Okay, thanks for that question, Anna. Would you like to respond to that? Yeah.
I'll respond to that. We are currently making use of the independent sector capacity and have done during this period, and that's been very valuable. That has been made possible through national contract for that capacity and funding. So in terms of longevity and moving forward, we will have to be mindful of that in the resource, but certainly in terms of that adding resilience in our system and separate spaces for the care of patients, that is something that we are very much would advocate and would wish to continue to do. We are also currently, in terms of our capacity and demand modelling, looking at how can we provide dedicated segregated areas of protective elective capacity, in other words, for planned surgery. Is it possible for us to have an area within the hospital where we could ensure that it was entirely separate from any non-elective areas where there could be exposure to the virus?
Can I just come back on that?
Of course you can, yeah.
Because the current arrangement is that the government has done essentially a block booking of private hospital beds across the country. But that's not like, well, the Chancellor of the Exchequer doesn't favour that as necessarily the best long-term solution. So I was wondering whether it'll have presumably be a local arrangement, but I was wondering who would be in control of making those arrangements. Is that again going to be done at a national level, or is this something that would be done at the level of the local health economy?
My answer to that would be, and certainly maybe some of the CCG colleagues as well may want to contribute, may have greater knowledge than I do, is I don't think we're clear on that at this point in time. At the moment, certainly within the hospital trust, our additional costs that we've incurred via COVID have been fully funded. And also there has been, as you've said, a separate block contract around the independent sector capacity. At the moment, whilst that's in place currently, in terms of the longer term plan, I don't think we have that clarity at this stage.
Okay, thank you for that clarification. Can I bring in Councillor Megan Swift, please? You need to unmute yourself, please.
Right. Has it gone?
No, you're still here, so continue, yeah.
Yeah, thank you. I didn't know whether it was, what is it? I've written it down. I didn't expect you to come through to me so quickly. No, leave it, Howard. It's okay.
Oh, okay, thank you. Any other questions on this particular area? Yeah, Councillor Hutchinson, please.
Thank you very much. We've heard obviously there's been a large backlog of people whose routine treatment hasn't been able to go ahead because of the restrictions that have needed to be put in place to focus on coronavirus. So there's there'll be large numbers of outpatient appointments that have been cancelled. There'll have been large numbers of operations that have been cancelled. It must be a nightmare actually managing those waiting lists to make sure that people don't drop off into the ether. I know in some parts of the country, what trusts are doing is discharging such patients back to the care of their primary care and asking for them to be reassessed and only referred if it's felt that re-referral is necessary. Is that an approach that's being taken locally, or are those patients who are waiting still being kept under watching brief by the trust?
I'll answer to that, and again, it may be other colleagues would like to add to my initial response. So during the pandemic phase, the surge phase that we experienced, we did have to contact patients to either defer or cancel their appointment. But what we also did do is that we offered them other options, which could have included remote digital consultation with a colleague and the ability to prescribe and to review their care. And we did also continue to provide us a smaller volume of necessary urgent face-to-face appointments for patients, and doing that with a limited number and protecting social distancing and within that. So we did, as I say, continue some level of activity during that period. More recently, we have reopened to accept referrals back into our services, into our outpatient services, and we are doing that in a close partnership with local clinical commissioning groups and GPs, with a shared understanding about how do we then prioritise for those patients for whom we accept the referral, the order in which those patients may receive care and treatment. And that is a piece of work that's currently in progress. So we are also within that recognising that we will not be able to provide definitive treatment for everybody all at once, and there will be patients quite naturally and their families who are anxious, worried, want to know what's happening next, and that we will need to wrap around this clear communication to keep in touch with those patients. And as you say, importantly, make sure we don't lose anybody in the system.
Okay, thanks for that. Yeah, anyone else wanting to come in on that particular question at all? Yeah, I'll bring in Councillor Barnes at this stage for the next question, please. Yeah.
Actually, Howard, it is related to that, in the sense that what we've seen through this pandemic is that through a lot of sectors that the need to face-to-face meetings, or the need to see physical people has not been required. And we've gone about FaceTiming and using apps in order to have doctors and GPs appointments. What work is going on to actually maintain that going forward? Because I think we've evidenced that there are certain things that don't actually need patients to come into the hospital, where they've seen perhaps a GP first, where they've actually seen a doctor, a practitioner at first, and they're going for a referral, and that referral is doesn't necessitate a need for the hospital. What work is being done to maintain that going forward, especially as the virus may take some time to actually work its way through the system?
Absolutely. As I said, we've taken the opportunity to want to really reflect and learn from the experience during the pandemic. We were already taking forward work to offer digital options for access for clinical consultation. The pandemic experience means that that has been the experience for the majority, and we want that to continue into the future. And we, as part of that, we've had discussion across all of our services with clinical colleagues around what are the things that they would wish to continue to keep doing, and this is one of them. We've been in a position of strength, I think, as an organisation in terms of digital infrastructure to enable that quite rapidly and the spread of that, and we want to sustain it. We are also currently undertaking a survey of all the patients that were contacted during this period and have had an alternate form of access, because importantly, we want to understand their views in relation to that. We've done the initial analysis, and as you're suggesting, that is very positive in response, but we're also cautious about making sure that whilst that's a majority are positive, there are some groups of our population who may not have access to technology or be comfortable to use it. And we want to make sure that we wrap around that a safety net so that we don't widen inequalities through digital exclusion. It was an existing and will continue to be a major programme of work for us with partners, because I know the experience across primary care has been a tremendous positivity around the provision of remote consultation.
Excellent. Anything else to add, Councillor Barnes?
No, thank you for that.
Councillor Megan Swift, did you want to come in?
I know how to do it now, thank you.
Good, marvellous, superb.
Yeah, you've scared me a bit there, Anna. A number of the contacts I've had with GPs over the last few months, which is a lot, it's been the best they could do, and you accept because you know it's the best you can do. But, you know, for it to be the main thing going into the future, you know, so I've had at least 3 calls where the doctors said, well, normally we would do that, but we'll try this and see if it works. And some of the things do feel as though we're going back to 1955. You know, but yeah, but you accept it because of the situation. It isn't that you necessarily like it. And I think the things I would like it for are the sort of things that in the past we would have seen the nurse practitioner, you know, so just my personal view.
If I may come back on that, I think that's a really valid view, and what I was trying to say about the importance we're placing on listening to the views of patients and the public. Whilst there is a strong positivity, it's not everybody and it's not appropriate for everybody, and we need to understand that as we move forward, so that it's not a generalist approach which is at detriment to for some people and for some conditions in their care. So I think it's a really important point. Thank you.
Excellent, thank you. Nobody else has indicated to speak, so thank you for coming in and presenting the report and the presentation as well. That's really extremely useful, so thank you for that. We're doing quite well. We're doing on schedule, so let's go on to the next subject, which is the South West Yorkshire Partnership. So we've equally received the presentation. Hi, Tim. So it's a case of, do you have anything to add to that? Maybe as briefly as possible.
I appreciate you've got a plethora of reports sitting in front of you, Chair, and I'll try and keep it bring out some of the points that may be different from others. First of all, I just say that clearly our response is all based on our usual business continuity plan, like everybody else, and making sure that we respond in a way that promotes a strong command structure and promotes communication up and down the organisation. One or two of the things that I just want to draw to your attention from the report that we've submitted is, number one, clearly people's mental health and well-being at this time is at the front of everybody's minds, and obviously would be at the front of ours. And one of the main things we wanted to do there, in fact, relates back to the points that Councillor Swift and others have made about keeping contact with people. So the first thing we did, the big thing, the message I had to get across is that we digitally enabled as many of our staff as possible so they could keep contact with people, make sure we could carry out remote consultations, although I appreciate that's not ideal. But I should also stress, not ideal for everybody, but I should also stress that where people did need face-to-face contacts, that did take place and it continues to take place. In terms of our inpatient services, one of the big hits, of course, for everybody, and things that everybody gets concerned about is in terms of visiting and not being able to keep in touch with people in the same way as they would normally. So we introduced a new sort of remote visiting scheme using some digital technology, which I think was well appreciated by all the people that we've spoken to. In terms of our staffing, obviously, we've got to keep our staff well to make sure that everybody else is well. And we did some important pieces of work there, particularly around enhancing our occupational health services and providing psychological support to our staff across the organisation, providing free meals and drinks, etc., to keep people going at times of pressure. I'm just trying to keep it brief for you. And the other thing I would say is that just coming on to the point that Anna made about sort of next phase, is that we're learning from what we've done now, looking at things we want to keep and continue to use going forward, being very clear about the things that haven't worked, but we've had to do, haven't worked as well as we'd have liked, and being very clear about some of the things that we have done that we wouldn't want to continue in any circumstances other than these, and making sure that we involve users, carers, families in those decisions as we take our next steps. The final thing to say, just to reiterate Ian's point about the great joint partnership working throughout all these times. People have worked very well together, good teamwork and strong spirit.
Excellent. Thank you very much, Tim, for all that, and keeping it brief as well. That's most helpful, so we can keep focused. Councillor Hutchinson would like to ask a question.
Thank you. We've heard from Anna Basford about the effects of social distancing on the capacity of the acute trust. I was wondering whether the inpatient capacity in the mental health trust was similarly affected or not to such a great extent, because one of the persistent problems has been the need to use out-of-area placements because of inadequate levels of inpatient capacity locally. Now, that might be a solution if it's a localized problem, but when the whole country is facing similar challenges, it may become less of a possibility. Is this actually a problem here? And if so, how are you approaching it?
Actually, during the initial stages of the virus outbreak, our bed capacity improved because a number of people didn't wish to come near hospitals, and so took the option that we would often promote anyway, being supported at home wherever possible. It really would be the last port of call to bring somebody in those situations. So in fact, our capacity improved during that time. Obviously, it started to rise again. But of course, one of the things we are interested in here is looking at the acuity, because obviously some people may need to be in hospital, but may be unwilling at this moment. So we're trying to manage that balance. But as it stands at the moment, we're operating, at capacity. We're doing well. We've minimised the use of our out-of-area beds prior to the COVID situation anyway, and we're hoping to continue that. Post pandemic, so the pressures aren't the same as they would be in the acute service.
Excellent. Colin, do you want to come back on that?
No, that's fine. Thank you very much.
Okay. Anybody else indicating to ask a question? I don't see anybody. So thank you, Tim, for presenting that, and the presentation slides most helpful once again. So thank you for that. And finally, on this section, we welcome the Calderdale Clinical Commissioning Group. So thank you for being patient.
Thank you, Chair. I know we provided a paper, but I'm not sure whether you've seen it. I've got a few slides to go through because the links on the internet I don't go to what I think we provided. So I'm just going to share a paper and spend a bit of time on that, but it won't be long, so don't worry. It's only 2 or 3 slides.
Good job too. Thank you.
Yeah. So I think we've just sort of recognised what Ian said earlier. There's been a lot around. Can we see that?
No, we can now. Yeah, something's happening. Yeah, here we go. Got it.
So we've touched on what's been going on in our general practice. So we have moved to a virtual total triage system, which is either by phone or by video conferencing. We have asked our general practice to continue that until at least the end of June, till we're confident in the test and trace process, and that we're confident around the sort of the decline in rates of infection. People will be aware we've got sort of face-to-face services in each of our primary care networks, so in the 5 localities. So that isn't every practice, and we've worked with the voluntary care service to ensure that there's transport needs if people need face-to-face as well. But we have predominantly used remote channels for primary care. That has been a long-term ambition of NHS Digital, but has probably been expedited because of COVID. So the use of telephone and video triage is here to stay in primary care, not necessarily as the primary, but as very much as an option as we listen to patients. We're hearing the sort of the 2 views. A lot of people like video and telephone conferencing, and a lot of people like face-to-face. So we've got to work out with general practice going forward what that balanced model is to meet the needs of our whole population going forward. We've also deployed our meds management team out into practice to help with repeat prescriptions, and we've seen a huge increase in the use of electronic repeat dispensing, which has mean less face-to-face contact, going in, collecting scripts, and obviously taking them to pharmacies. We've also been manning the testing hub, which Ben touched on earlier in the testing and trace, which is up at the fire station. And we've been working with our social care colleagues to ensure that we do key workers in care homes and provide that support to testing outside of the acute setting. I suppose in the last few weeks, we've been heavily involved in working with our public health colleagues, particularly around the care home support programme, and ensuring that there's been a significant rollout of infection prevention control training. We've obviously been working with our community partners, Quest, to ensure that there's PPE supply and testing of staff where relevant, and testing of patients as well on a continual basis. All this work has been really invigorating for our sort of integrated approach and working across boundaries. It's broken down quite a number of sort of barriers, and we've seen fantastic results in discharges from hospital, from discharges into care homes, and particularly, I suppose, the work that we're quite proud of is the retreat, where we've worked with both the hospital and social care to have a COVID and non-COVID site, and we've received some really positive sort of responses from both patients and from the providers about how that has worked to enable the flow of patients around the system. So I think the slide there sort of summarises some of the work we've done jointly to ensure that we have had, unfortunately haven't had to need to use a number of facilities, but we have had it in sort of our back pocket just in case. And I think one of the learnings that sort of Ian touched on earlier is, I think we are in a good place that should we get a second wave, we're able to mobilise these things quite quickly as well. We have been recognised in sort of West Yorkshire, have been in a really good place with regards to our system working and being able to have those sort of distinct sites for patients to go to stop the spread in care homes. I think the area that's sort of focusing on a lot of minds now is the reset sort of thing of how do things start picking up with regards to activity. Anna talked about the referral management program that we've got working, where we've got our GP clinical leads and our consultants in the hospital working on managing that backlog. Our hospital is the only one in West Yorkshire that has its electronic referral system open. So we are able to manage engaged demand. We saw some great figures today around how the hospital are using different models and doing different triage. And we're looking to expand the sort of the guidance that general practitioners can get from our consultants to be able to manage the families and their concerns in the community, whilst there is going to obviously be these delays at this moment in time. I think the big difficulty we've got is we are waiting for a lot of central guidance, and that isn't coming through very quickly. We obviously want to move forward as fast as possible, but we want to do it in a safe way, and we need to know what sort of resources we're going to be working on. We are able to mobilise quite quickly in all our staff working remotely, and we continue to have a policy of work from home. We are exploring what that means to work with Dean Clough with regards to returning. However, as people will recognise with schools and everything, returning to buildings is really difficult to ensure that you maintain a safe environment. But we also recognise the damages of people of just being at home in their four walls and social distancing. So we've got a lot of support to our staff around their mental health and their well-being, and ensure that we've got regular diagram support in place. A big concern we do have, and I think the council recognised it in one of their reports, is sort of finances. So for the first 4 months, our standard planning process was put on hold. As Colin alluded to earlier, a number of contracts have been fixed and blocked, and we have had a reduction in the amount of allocation that we'd get each year. We don't know the full impact of that until we get the new planning guidance, which is likely to arrive, we believe, sometime in early July. But we are working very closely with the independent sector and CHFT about what capacity we do have to enable that reset to happen in a safe and manageable way going forward. Happy to take questions there, Chair.
Okay, if you just like set the slides down so I can see.
There you go.
Yeah, marvellous, thank you for that. Councillor Hutchinson, would you like to ask a question?
Yes, thank you, Chair. You read my mind. Good for people who are sort of approaching the end of their life or possible end of their life. It's very good practice to actually discuss their wishes as to how they want treatment as that time comes. And there was a big rush at the start of the pandemic to try and get those wishes clear. Some CCGs were rather clumsy in the way that they approached this and came in for a lot of criticism. Obviously, it is something that's not just a one-off, it's something that needs to be continued long-term. How is Calderdale CCG and its primary care staff approaching that question?
In a collaborative manner, Colin, we have an excellent working group which has representatives from Overgate and from the Trust and from primary care and from the voluntary sector and importantly GPs. I think you're referring to that lovely Welsh letter that got circulated by GPs asking for stuff. We didn't do anything like that. What we did do is predominantly sort of work in similar lines to the shielded service. So we did contact patients, GPs did contact to ensure that they had the support and the care and packages in place. No one was pressurized to make decisions, but it is done in a collaborative way and sharing information between all parties to ensure that everyone had the needs and then they're met. I think end of life, our biggest concern early doors was concerns around access to drugs to ensure that people had their pain managed appropriately at home. And I think in Calderdale, we managed that as a system really well. I know other CCGs had trouble accessing drugs, particularly in bank holidays and whatever. But I think that's paramount to how, particularly on end of life, we work as a system, not just as a CCG.
That's good to hear. Thank you.
Okay, Councillor Barnes, please.
Thank you, Chair. I think this is a similar vein to the question I asked to Anna early on. In that, I think there is a big difference between the GP practices and their connection into the local community. And what I don't want, whilst I agree there needs to be more digitalisation and potentially triage, I don't want this to be a default setting, because that's going to affect quite a large section of our community who appreciate that direct connection that they have with a GP practice. And I think that's a concern of mine, that we just don't want to, that we're just not going to go straight down that route. How are we going to manage that going forward? I think within that primary care, within the GP sector.
So I recognise the point, and I think all our general practice recognise that. I think we recognise, and we're taking the time at the moment to work with our primary care networks and all our general practice to understand what our future model for primary care is. It is a balance between the use of digital, but also face-to-face, particularly those with long-term conditions that need a certain amount of management and contact. And I think what we've recognised with our general practice colleague is this is probably the first time in 70 odd years to actually really look at the day and how we actually are more proactive and help manage people and have that balance of both digital and face-to-face, recognising there are competing needs. So that's probably one of the top things that's occupying our GPs at the moment is how we can accelerate, because there is a huge demand for people wanting to be able to have good access to general practice. You know, we regularly hear the 8 o'clock frenzies to get an appointment pre-COVID. We want to move away from that so people can have access. There has been investments in extended hours, but we recognise we've got to find what that right model is, and a lot of time and effort has been spent on that at this moment in time.
Okay, thank you. Councillor Stephen Lee, please.
You're on mute,
Stephen,
Councillor.
Councillor, you're on mute. There we go.
Okay, we're okay. At the last meeting of this board in February, pre-COVID, we talked about dentistry in Calderdale. Not everything was ideal in that regard, but there's been some terrible stories in the press nationally about people suffering terribly for the lack of dental services. Have we got this situation sorted out in Calderdale? It appears that some people elsewhere, I hope, have been suffering greatly, and certainly hope that's no longer the case here.
Dentistry's been quite a thorny subject. To be clear, the CCG isn't responsible for the commissioning of dentistry services. That is an NHS England national process. We have been working closely with them to ensure that we've improved the communication of access, and we've worked very closely with the hospital because there's been concerns about the amount of activity for people turning up at A&E with just general toothache, and obviously that's not the most appropriate place. So I think there has been announcements in the last week or so, and I think there's up to 50% of practices are back open. We recognise in Calderdale we have quite good access, or we had quite good access compared to the demand in other areas. But it is an area of focus that we continue to work on with NHS England. There were emergency services available, but I think the signposting and the communication wasn't as good as it could have been. And we worked hard with A&E and GP and NHS England to improve that through social media and everything.
Okay, thanks for the response. Anybody else indicating to ask another question? Right, guys, I think we've come to the end of item number 5. So thank you very much for your patience. Thanks for your questions. And thank you, most importantly, to everyone who's attended and provided us with their very comprehensive reports and very comprehensive responses. So thank you for attending. So let's move on in that case. So item number 6 is GP services in the Upper Valley.
Chair, I will just need a few moments to bring people in and out. So
that's fine, that's okay. Just bear with members in that case. Are we there, Kirsty? I think so. Right, good.
You on this one?
You're doing well. You're doing a good job, Kirsty. Thank you for your support in the back. Right, okay, so let's move on to item number 6, which is GP services in the Upper Valley. I think everyone's had the copy of the reports. It just has to be said that actually Councillor Sweeney and myself met with a number of people and asked some, quite robust questions. Alex, would you like to come in on this?
Sorry, Chair. I just think there are a few people missing out
Right,
for this item. Kirsty, I think we need Nigel Taylor to come in, and we also need Councillor Dacre as well, I believe.
Sorry, it's just taking some time in the background.
No problems. Councillor Baker, I think. Ah, no.
Yeah.
Councillor Dacre's here now.
Okay, fantastic. Okay, well, thank you. Welcome, Councillor Dacre, to this section of the report. So everyone has had a copy of the report. Both Councillor Sweeney and myself met with a number of people around the table in the Todmorden Health Centre. So I'll probably open it up to questions, I think, at this stage, if people have any questions about the report. Councillor Hutchinson.
Thank you very much. Todmorden Health Centre was designed as what they called a Darcy Centre to try and provide a facility where a wider range of services could be provided that bridged primary and secondary care, sort of bringing care closer to the patients. But one of the limitations was it's relatively time consuming for clinical staff to travel from Calderdale or Huddersfield to Todmorden and back again, which eats into the time to actually treat patients. But we've heard now that there are problems that with social distancing, you can't do as much in the same space in the main hospital, so you need more space. Well, there is a fair amount of space at Todmorden Health Centre, and people are wondering what can be done with it. I just wondered whether there was scope for revisiting the idea of providing more outreach services from secondary care in Todmorden.
Would you like to come back on that? Debbie, would you like to? Oh, Nigel, yes.
I mean, there are existing, or up until COVID, there were existing secondary care services happening in Todmorden, and there is definitely, and there were plans before COVID to investigate doing more things in that building. So certainly CHFT are wanting to bring further services out into the centre at Todmorden, and we have had conversations about bringing in a digital hub for patients who may not have as good access to IT, that might allow distance consultations to happen where the patient comes to Todmorden, but the clinician sits in Halifax or Huddersfield. Those were conversations that were beginning before COVID. Obviously, things have been put somewhat on hold in the current environment, and we've been utilising the space in that building in different ways, providing it's been our primary care hub during the COVID epidemic. But actually just today we did restart some conversations about how we might start to think about using some of the digital technology that we've embraced in the COVID epidemic and looking at how we might use those to bring services out. But certainly, yes, there are lots of plans to exploit the space that is in that building.
Kirsty, can you bring in Debbie and Neil Smurthwaite, please? Right. In the meantime, any further questions? Yes, sir. Councillor Barnes, yeah.
Thank you, Chair. I think the biggest, in reading the report, the biggest takeaway I took was the issue of recruitment. And, you know, I think, I'm not sure, having only 2 years, that issue is going to go away very soon at all. And I just wondered what the sort of short to medium term plans, because that's effectively what we're looking at, but then developing into the long term plan we are going to do to resolve this, because I think that's, to me, was the biggest thing to come out of this report.
I think it was. I think we agreed around the table at the time. That was one of the main areas. Nigel, can I bring you back in, please? Yeah.
Yeah, I mean, recruitment in the Upper Valley, both medical staff and support staff, particularly nursing staff and advanced nurse practitioners, has been an issue for the last 3 years probably, and it certainly isn't going away. I think, you know, the practices in the Upper Valley have had to be creative. We've certainly got less doctor staff than we would ideally like, and we've had to do things differently to fill those gaps. So, you know, it remains a peculiar issue that we do struggle particularly to recruit GPs in permanent posts in the Upper Valley. I think it's a geographical issue particularly, and that most newly trained or younger GPs are coming out of training schemes based in the bigger conurbations and are not looking at a more rural you know, place to work as being all that favourable. We do our best to try and help that, and we've had to be creative to fill the gaps. You know, we still are ongoing trying to recruit at the moment, but we are reasonably staffed, but in a different format than what we were 2-3 years ago.
Excellent. Neil, can I bring you in, Neil Smurthwaite? So welcome back. Sorry.
Yeah, thank you, Chair. Councillor Barnes might not sort of like this, but I think we just talked about the balance between using technology to deliver services. And I think what we have to realise is if in areas like this where they are in short supply, to have people on the ground like Nigel, some of the remote stuff might not be delivered from that area. We might have to use our primary care networks to deliver extended access, or to be able to think differently. And that's sort of some of the conversations we're having with GPs about how models can change to enable GPs in Hebden and Todd be GPs and look after those with long-term conditions and have that face-to-face. But if there's a generation that wants your app and your consultation, that can be done remotely, and the technology is starting to be there. But I think with the resources we've got, I think it will be an ask long term for GPs to be able to offer both of those all of the time, because as Nigel says, recruiting is difficult. So we've got to think different and flexibly about how we use the Calderdale workforce to help deliver the services for that population.
Chair, can I just come back? Because Neil, I actually agree. I'm not disagreeing with you on that, in the sense that we need, you know, we do need to look outside of, oh, what a horrible phrase, the box, so to speak, on this one. You know, any minute now I'm going to revert to blue sky thinking. But have we? I mean, this is a very brutal question. But have we actually asked people why they don't want to come and work in Todmorden or in the Upper Valley? Because, you know, you look at where it sits geographically, which is, you know, roughly halfway between Leeds and Manchester. Councillor Dacre would probably agree. It's a beautiful part of the of Calderdale. A lovely place. It is a very nice place to live, and it should connect to people in Oldham, in Rochdale, and people all around the area. So it just seems almost counter thinking to me that we're struggling to get people to move there or to work there.
Yeah, Nigel, come in. Yeah, Nigel, yes, please. Yeah.
I mean, I agree. I mean, I'm a GP who's been working in Hebden Bridge for 25 years, and exactly as you say, a beautiful place to be, and it attracted me to come and work there. Strangely, it doesn't seem to be attracting the younger ones. I mean, we literally at Hebden Bridge interviewed for a new GP 2 weeks ago. We got as far as offering him the job, and the response we got back is he's changed his mind. It's too far. I don't think I can commute from Bradford.
I think
Councillor
we've done a lot of work, Councillor Barnes, over the years to try and understand that, because like you say, Hebden's been voted as one of the top places to live, and I think what we're trying to work with Nigel is understanding what that model, because you get so far and something holds them back. Yet in other parts of Calderdale, we're not having any trouble retaining or recruiting, and I think Nigel looks on quite enviously as to, I live in Hebden, why don't you want to come here? Why do you want to be in Elland rather than Hebden? But
it's the car parking, Neil. It's the car parking. It's terrible in Hebden.
There's certainly an issue about the travelling down the valley. That's certainly
it is, yeah.
Times.
And I think that's where we've got to work and use the skills within Calderdale, because we do have pockets where it's not a problem, but pockets where we do for some reason, and that's.
And as Neil alluded to, we have used capacity across Calderdale to support certainly the extended hours and some of the increasing access things, and certainly within the last few months with COVID, we've used by doing things by remote access, we've been able to use people who are not actually in the Upper Valley to support. So there are definitely positives that have come out of the last few weeks and months working differently and by doing things using technology.
Thank you for allowing me for that, Chair. Thank you.
Thank you. Colin Hutchison has a suggestion.
Well, we know that with hospitals where it's difficult to recruit to that are not necessarily central hospitals, that trying to increase the number of people doing training posts within those hospitals can open their eyes to the benefits of working in those situations. I was wondering how much you're involved with the GP training schemes in the Upper Valley, so that people can actually appreciate the delights that Councillor Barnes has described of living in Todmorden. And is there any scope for actually luring GPs in training to the Upper Valley and then keeping them there?
Nigel, would you like to come in on that? Yeah.
Both Todmorden practice is an existing training practice and has trainees. Hebden Bridge practice has been a training practice for many years, and in fact I trained there. We happened to be on a hiatus because we had 3 trainers, all of whom for a variety of reasons have moved on. We currently have a GP who is training to be a trainer. So we will be reinstating ourselves as a training practice as soon as we practically can, although she has just returned from maternity leave. But yes, the 2 big practices have a history of being training practices and tend to remain so.
Okay, thanks for that. Councillor Clark.
Thank you, Chair. This is asking for clarification, really. On paragraph 3.4 of the report, it says with regards to local services, these are completely split across the 2 sites, and there was previously a feeling of treading water because of the contract in place. However, there is now a different focus, and Locala is working from base 0. Particularly, Locala is working from base 0. What does that mean? But also, what is the totally different focus? Can anyone answer that? Just need clarification as to what that paragraph means, really.
Mike, can you come in on that, Mike? You're on mute, I'm afraid.
Hello?
Yeah, sorry, Councillor Mike, would you like to come in? Oh, that's better.
Sorry about that. I was just trying to locate the report. I'll have to come back to you on that. I'm sorry, I can't give you an answer at the moment because I'm not sure myself. But we will give you a reply about that. And this is possibly something we've not perhaps worded quite correctly. I don't know whether Nigel has got anything to add on the Locala situation.
Yeah, if Nigel comes in on that. Thanks,
Yeah,
Mike.
obviously, I didn't write the report, but I think I understand what they're trying to say. Obviously, the Locala service was running on 2 sites. They were a site based in the centre of Halifax and a site based in Todmorden. So they were, basically one practice, but 2 very distinct populations and 2 very distinct offers of service. The contract that they were running on was running until the end of March of this year. I think that's where it's talking about the difficulty they had and were treading water because they had a contract that was due to end, which made recruitment very difficult. And then at the sort of last minute, there was the decision to extend the contract for just half of the practice, just the Todmorden half, and that's the new focus.
So what is base 0?
It means
I think what
starting
they're saying is they had no permanent staff in post of the end of March, and because they had a contract that was due to end, they really struggled to recruit anyone on a permanent basis. So when they got the new contract to extend for a 2-year period, they literally had no permanent staff employed. So that was their base 0. They do now have a long-term locum employed at least.
Okay.
Which gives them
explains about that in the next.
I think that's what the report was trying to say.
Neil, would you like to quickly come back on that?
Nigel mainly answered that they started from scratch, which hence base 0. So they lost a lot of staff with sort of the contract coming to an end, and so they rebuilt and start from again. And we went into a new contract relationship with them, doing a sort of a full cost recovery with them. So that's what it means, rather than so they weren't going from an existing workforce that they were able to move from one to the next. They literally had to start again.
Thank you.
Okay, Councillor Stephen Lee.
Right.
Now you've muted yourself again. Councillor Stephen Lee, you're on mute, I'm afraid. There we go. That's better.
Yeah, I'm sure everybody would agree that we have great appreciation to Councillor Howard and Steve Sweeney for this report, and it's evoked a number of questions about the Upper Valley, which probably can't be dealt with at this scrutiny meeting, but clearly there's a number of things arising from the report, and that's good. That's come out of it. I see that the possible course of action would be to have a second report for the Lower Valley or elsewhere in Calderdale. And I think that this is such a good piece of work. We ought to get on with the next piece of work, if it's to be the rest of Calderdale, to avoid any repetition, because there's clearly things that will be applicable to Todmorden and the Upper Valley that will be applicable elsewhere, and vice versa. So I think it's a great piece of work, and certainly one of the courses of action which is recommended, I definitely think we should get on with as soon as possible, Chair. This is the sort of thing that we need to get to the nub of the arguments and ask all the questions publicly, and have a really robust debate on all of these things. So thank you, and I hope we will do some further work on this.
Excellent, thank you very much, Councillor Stephen Lee. That's most helpful. Mike, you just want to make a comment?
Very briefly, thank you, Chair. I'd like to first of all say that Councillor Sweeney phoned me this afternoon and he's not well, so he sent his apologies for this item. We asked Councillor Sweeney to get involved because he's involved in the Primary Care Network Partnership up in the Upper Valley. I'd also like to thank Nigel Taylor and all his colleagues for taking so much time to meet us. It was a really useful meeting. The reason we started, if you remember, members at the Upper Valley, was because of the APMS discussion, the 5 practices you discussed last December from recollection. And just to pick up on Councillor Lee's point, I think one of the really good things that's come out of this is having had such a good experience up in the Upper Valley in meeting with a couple of councillors, is to go to the Lower Valley next, and then probably to each of the primary care network areas in due course. And it's a really good opportunity for members and GPs and their colleagues and practice nurses and so on to meet and to look at some issues. So that's all I wanted to add, Chair.
Excellent, thank you very much for that. So I think I certainly concur with that, and I say my thanks to Nigel and the rest of the people that attended. Nigel, can I just bring you back in?
Yeah, I just wanted to add that actually we found it useful too. You know, I think the 3 practices, the conversation we had, the questions we were asked, I think it was all a useful experience. And you know, we have I think made individual practices have made changes, you know, in terms of the services that we are offering, both, you know, before the actual meeting, in response to the questions we were asked. I think it was a really fruitful experience on both sides.
Yeah, totally agree on that. It was excellent. So thank you for that. Anybody else indicating to raise a question? Okay, well, thank you for that. And I think we go with the idea of looking at the Lower Valley and proceeding with that as soon as we possibly can. So thank you for item number 6, members. So we now need to item number 7. So it's the Adult Health and Social Care Scrutiny Board Review of the Year. I think it's self-explanatory. So any comments, members? No. Okay. Well, let's.
Chair, can I just come in? I just want to know, what do we do? What is this going to be published and distributed anywhere, or are we just going to leave it like this?
Alex, would you like to come up?
Sorry, yeah. So I'll do a brief overview, a very brief overview for the report. So it's the first of its kind we've done for the Adult Health and Social Care Board. We have done similar reports for each of the other boards with a view, I think, to merge these together into one larger report to take to Cabinet to provide a review of what the scrutiny boards have done. The report basically provides an overview of the items that have been looked at over the previous municipal year, but also provides some suggestions perhaps for areas of work that could be undertaken going forward. If I can just point a few of these out, that one of them is the GP services, and we just touched on that there, the possibility of looking at the other localities in Calderdale. I picked up that the topic of technology and the use of technology in health and social care have been touched upon last year. And perhaps in the wake of COVID, it's a very pertinent time perhaps to consider this again, and the opportunities perhaps going beyond COVID for this. So that's why that has been suggested there. And also on the basis of health equalities or health inequalities arising from COVID as well. And this has been quite a well documented topic. Something I circulated a report around recently, I think from Public Health in England along these lines. So again, not currently in the work plan, but something perhaps to consider going forward. I think I'll just finish by saying it's, like I say, it's the first report of its kind we've done. So if there's any feedback or comments you might want to see further down the line, then do get in touch. Or if you have any thoughts about some of the items that were raised, particularly in the planning ahead section of the report.
Indeed,
I don't know if Mike wants to add anything.
Thank you, Alex. Mike,
just very briefly, Chair, I'd like to thank Alex for the work that he's done on this report. But Alex is incorrect in saying it'll be going to Cabinet. Cabinet are the people that you scrutinise. That wouldn't be appropriate. It's going to full council.
Apologies.
Your report of scrutiny.
Excellent, thank you. I think actually, as we pointed out in our informal meetings, the agenda of the Adult Health and Social Care Scrutiny Board will possibly evolve because of this situation, and we'll probably focus more on local things that, you know, what we're delivering within Calderdale as well sometimes. So actually, you know, very much welcome the report, Alex. Thank you for your hard work on that, especially with you being in post such a short period of time. So I think you fit in extremely well. So with that, I'm going to recommend that we approve the report that's been issued, and we then can move on to item number 8, which is the work plan. I think it has been circulated, as I explained a few moments ago. I think we will be continuing to work with that where it fits in appropriately, and where we feel we can add something to the panel. I've always said along the way that as a scrutiny panel, I want to add value to what we actually do here on the scrutiny of the adults. And if we feel that something is just coming for being noted, then we'll circulate it in advance. So does any member have anything else to say about item number 8, the work programme? Right, okay, there will be a short break because we are going to item number 9, which is an exempt item, and we need to ensure that actually it's not being broadcast. So Kirsty, over to you, please.
Okay, I'll stop the stream now. So if we just wait a few moments and I'll give the go ahead when we can resume the meeting.
Just let me thank anyone that has joined us on the webcast. I hope you found it extremely useful information. Thank you.